Good morning for all around the world to our meeting of the structural heart life cases, broadcasting directly from the cardiac catheterization at Mount Sinai Fuster Heart Hospital. My name is Pedro Moreno. I'm a professor of medicine, and I'm going to be your moderator today. We'd love to hear from you, so please send us your questions right from the website or from YouTube. And remember, all our previous cases, as well as today's, will be available at www.cclifecases.org later this afternoon. Now, let me transmit to Dr. Fuster, to Dr. Kini and Dr. Sharma for the live case today. Thank you.
All right. Good morning to our live audience. And as you know, this event every month.
To see how deep
Next month will be our New York TV conference, which on December 5th, which Dr. Moreno will say later on. And therefore, the next month, which is supposed to be with a follow-up, so we probably will skip our routine monthly our structural program. So with that note, we try to bring latest of the cases to show. Some people say that, you know, we are exposing our own fault, but that's the life is all about. So we need to understand what we may have done differently to improve the overall outcome of our transcatheter patients. So this case will illustrate that. With that note, I want to introduce my colleagues, which are all our usual, I would say, the frequent flyers, myself, Dr. Samin Sharma, Dr. Tang, Dr. Kini, Dr. Khera, and then we have our Dr. Lerakas is on the structural, and Dr. Benjamin Salter as our chief anesthesiologist. So then we have two fellows. Actually, we have total 3. Should be 4 now with our program, which will be about 850 plus this year, all the transcatheter cases. Then we have Akshat and we have Taka. All right, with that note and rest of our staff, cath lab, the nurses and technicians, as usual, we want to start getting into this case, which is slightly delayed today. And this is our shown here. So what we are going to do today, again, the Redo TAVR for significant PVL in a Navitor valve using Sapien-3 Ultra Resilia. So Dr. Kini did mention to me that why we are showing our own the TAVR failures, but I think it's reasonable to understand because this is a learning field and the new valves are coming. We need to understand which valve is good for which area. We have a lot of we have written a paper of the valve choice in JAMA Cardiology. We actually recently paper has been accepted, although with some changes about trying to talk about the update in new areas of aortic stenosis beyond just severe classical aortic stenosis. So this is the 60 patient, our episode number 64, 77-year-old patient who presented with dyspnea, fatigue, and pre-syncope. Patient had a TAVR on December 5th, 23, was done here at Mount Sinai, and we'll go through that. And we use a 29 millimeter Navitor valve. Patient did have a CAD. There was question at that time, should we use a Sapien versus Navitor? So decision was made because of the frequent CAD issue, but there was no issue with the CAD. We know that even the question is whether maybe evolute may be slightly different, but patient with the self-expanding versus balloon expandable, the balloon expandable do very well in terms of future coronary access. But now, even with the self-expanding with the FX plus, things are better. But whatever the decision was made, there was a lot of discussion at that time. That why one valve, Sapien versus Navitor, but finally decided as a heart team they go with the Navitor, maybe gave a bigger lumen. Patient had a PCI in the past, and patient had a kidney transplant twice, normal ejection fraction, and then at that time had a moderate to severe. Now patient has moderate to severe paravalvular aortic regurgitation, and we'll show you with very little gradient. Rest things are okay. Angiogram has been done, and this is actually, if we can play this. Should be able to play because this is important. Yeah, this was the last time, which is in December. So here maybe we can get a lot of expert here with the starting with the Gilbert and then Anu, that what we think we could have done differently at that time. Time 0, which is will take us back, back to the future. So 12.5. Could we have done anything different? At the gradient, actually, we had the hemodynamic tracing. Gradient was less than 2. So valve from the diastolic point of view, things were okay. There seems to be a little bit of a trace or 1 plus and we can ask the echocardiographer, although STEM may not have restudied the old echo post discharge, but we'll show those clips later. So Gilbert, could we have done anything different? And Anu and Sahil, anything you would have done different here? Maybe more bigger expansion, post dilatation, or what?
Well, the decision making here initially, to your point about balloon expand over self-expanding, this patient is two-failed renal transplant on multiple immunosuppressant, and you can see the CT scan later. There was a chunk of calcium, even though it's a long access to the annulus LVOT. We're about obviously rupture in this kind of patient because we know steroid use is the highest predictive risk of rupture. So that's why, because also patient had a young patient, 79-year-old, with a previous PCI, that we thought that Navitor is kind of the best trade-off of all the above. So you can see that here in Sahil, why don't you comment on the implant depth? Certainly it was not a straightforward case, a lot of calcium and the native anatomy that we'll show later.
Yeah, I think if you see the rings, the bottom of the ring is 3 millimeters, the top of the ring is 4.5. So this is slightly deep. If you look at the implant depth, it's 6 on the non and around 10 to 12 on the left. Makes it really challenging because most of the radial strength of the Navitor valve lies in the intraannular frame where the leaflets are. So going in, if you have a deep depth, you do miss their sealing skirt and you can have some leak. Now, the other question here is also, should we have post-dilated? Because the frame definitely looks slightly underexpanded. Now, that said, this patient was at high risk for root injury and root rupture, and we were really concerned. So all in all, I think at that time, given the situation, this was a good result, in my opinion. You have low gradients, you have minimal leak.
Okay, if you go back to the CT scan, because the choice of the valve is very important. Right. I know both of them mentioned that there was a lot of calcium. There was just a little bit of calcium on one area. So if it were me, I would have gone with the Sapien valve at that time. So now what happened with this valve? That definitely it was low. If you see that, if you see the skirt is below the annular plane and your radial force is below the annular plane. So going back to your question, could we have gone back and dilated with another bigger balloon? I don't think anything would have happened. Like Sahil mentioned, the radial force is already below the annular plane, everything is below, and that is why we started seeing this paravalvular leak. At the given time, yes, it looked okay. But I think subsequently it all depends how the valve was positioned. It should have been at a higher.
Yeah, you post dilated with a 22 millimeter true balloon, and so now this is.
I said even if you post dilate, what's going to happen? The radial strength is below the annulus. It's going to recoil because it's just nitinol frame will recoil again, and it's not going to work. So this is the CT scan. Yeah.
At that time, the two chunk of calcium, as you can see here, LVOT and perimeter, the valve size was correct. And then previous tower CTA, these were the, so it looks like quite a bit of calcium actually.
It's very heavy calcium. Typical patient with renal disease, right? Which you've seen patients with dialysis, for example. This patient renal transplant. So not surprising that really truly calcific AS, and Dr. Keeney's point was right, that the annulus is true size for the 26 Sapien-3. The LVOT is smaller though. So of course then you might have to think about whether you want to take volume out to avoid any kind of potential root injury. Next slide.
Sorry.
If you want to show the previous slide.
Okay,
so
1 second.
The previous. Yes, if you see what is the calcium, because I would like to point this on the echo. It's around 5 o'clock.
Yeah.
That's where exactly I will show you is the PVL. Exactly there.
So that calcium, because we also learned by doing our experiment, just to give rough idea, I cannot say for sure because the data are not public, that overall US use of the tower valve in America at present is about 72% is the balloon expandable, means basically the Sapien valve, and about 23%, 24% is the our Evolute group, and about 3 to 4% is Navitor is being used. Now, any new valves with the accurate new end. So we'll talk about whether anything else will be available in the market. It's to be seen. I think these will have these 3 valves for a long time.
Why don't we have Stam show the echo now?
Yeah.
Then there's Stam, can you
Yes,
just go
yes,
live on the echo,
Yep.
please?
Yes.
It's got some really nice images showing
Is it live?
yeah.
Yes.
Yeah.
Go ahead.
Yes,
Stam.
thank you. So this is a 4-chamber view, normal LV, normal LV function.
Can we
As you can
finish
see,
by
a lot
10?
of maternal calcification.
Finish by 10.
Oh, yeah, of course, of course.
This is the mitral valve
Wow.
3D, severe calcification. Both MAC and the leaflets are very thickened and calcified. Mild to moderate mitral regurgitation. The gradient is 7. This was when the heart rate was 16, was 116. Now the patient was cardiovertices then. Valve area of about 1.7, so moderate mitral stenosis through to severe mitral calcification. Mild to moderate tricuspid regurgitation. PA pressure about 55 millimeters mercury. Left atrial appendage was clean. We checked this before cardioversion. And this is the valve. X-plane, as you can see, the leaflets open well, so no stenosis. And this is the with color. As you can see, if you use what view we use all the time, you know, the normal view, you see no PVL, no valvular AR, and no PVL. So you may miss the PVL. So very important to play with the probe, especially with this patient. As you said, that we were not able to get gastric images because we cannot advance the probe. And this patient did not have a TE here. The TE was from outside, so no gastric images. So very important to play with the probe because if you take only this image, you completely miss the PVL. And look at this, what I'm telling you, and I saw on the CT, look the PVL exactly where the calcium is, if I can point out.
Yeah.
So Stan, these are single jet or multiple jets?
A
No,
single
it's,
jet.
the main jet is here.
Yeah.
As you can see where the calcium was, exactly.
Yeah.
Exactly where the calcium was.
Very good correlation.
See this?
Brilliant.
And this 18%, which is moderate range of PVL, he has a very small posterior jet, but mostly is underolateral.
Yeah,
about
but
the 5
Gilbert,
o'clock,
you
exactly.
think we have
Exactly
a
where the
risk?
calcium is.
Yeah, understood. Yeah.
Yeah. And,
There's a risk of rupture even now.
No, yeah.
Well, I mean, there is, but I think we have to do what we have to do. We just have to be very slow in our inflation for the second valve, you know, because now you have a stand frame in place. But you're right that really aggressive inflation has, even in Redo TAVR, has led to rupture before in totally. But yeah, let's go back to the slides and we can go over some of the CT images. Next slide. So we've gone through the index TAVR CT. So that's why it's important to get the index TAVR CT, right, Dr. Sharma?
Yep.
That you understand the mechanism, you correlate with the echo. People say just look at the post TAVR, but then you missed what the original reason is. So anyway, so we can go, go straight
This is the
ahead.
follow up the TTE, which is
Not in
fine.
Navitor.
And then with this patient came back.
Yeah.
On 9.7, and look at the now have moderate to severe PVL,
Yeah.
which was shown.
Yeah.
Very low gradient. Valve is moving fine
Yeah.
with a valve area of 1.4
Yeah.
centimeter square. This is the TE as exactly has been shown. So we just had to go further because TE we understood quite a bit of teaching. This is now.
Right, so this is so we do in vivo sizing. You can use Mini Bapat's app to plug in the numbers, but you can see the valve is actually reasonably expanded to native anatomy, right? It's right around 520 something, so area of a 26S3, and you can see the diamond coming up, the quarter diamond, the no one. Next slide. They all within range of a 26 Sapien-3, and you can see that the valve got a little bit constrained. You know, it's a 29 Navitor, but it's not going to be 29. We know that. Just like Evolut, the same thing. But overall, it's pretty much evenly expanded. You know, given the extensive calcification. Next slide. And so what we're trying to show you here, that white line, is where the coronary takeoffs are, right? Because the one thing about Redo TAVR in general, you don't want to obstruct the coronaries. And thankfully, this patient has a very big root. So you can see the white line is below the right at the level takeoff of the left main and the right. So you're not going to have coronary obstruction at the top level where the commissures are for the Navitor. Next slide. So you can see the commissures are not aligned. The Navitor right now cannot have commissure misalignment, but the cells are so big, it really is not a matter here. Next slide. So you can see this is kind of the frame looks like on CT. Next slide. So you can see that is kind of where we're going to roughly position the Sapien-3 is to be more towards the commissure level. We'll start maybe a little bit lower because sometimes these valves have the tendency to ride up. But the key is to make sure you have good seal against the PVL. So you don't want to implant too high, but you also don't want to be too low because then you impact on the mitral valve. Yeah.
Good, very good. And patient has some mitral stenosis.
That's right. And then you can see there's a left-sided kidney transplant on the access, so we're not going to touch that side. And then we're just going to use the right-sided access, and we use the pigtail from the right radial in case we need to do any injection.
So they're basically, to sum up, this patient is the failure of 29 millimeter Navitor TAVR because of PVL, not because of the valve.
That's right.
Because of PVL. And so we are doing now redo TAVR using 26 millimeter Sapien. Is there some extra CC or minus?
We're going to +2, but we will have to go very slow in inflation because you don't want to rupture, like I said, the native anatomy as well. So, but I think it should be okay.
Okay. And then we have crossed it now. Did we put a cerebral protection device?
No, we won't be able to because we have to use the right radial for the pigtail.
Understood.
Dr. Kinney, you want to show the crossing?
So let's look at the fluoro and echo now, please, and hemos, all three screens now as well, please.
Yep.
Can she go over the fluoro?
Let's go to fluoro.
Showing,
we're going to show now.
Yep.
So at least crossing, you see that you have to be careful as we are going crossing, use J wire and pigtail. Now you're getting into the sinus, so don't pull back.
That's it.
Yeah. Way easier than I would say the evolute.
No, but in this case, it's a little different, Anu, also because this is purely valve is working good. It's all because of the paravalvular. But yeah, many times actually crossing these valves are very difficult. We learn.
No, what I meant is when you're crossing the evolute, we those diamonds.
Yeah.
Somehow the catheter gets into the diamonds more often than here. These are larger. Do you agree?
So the coronaries are good. LA diagonal PCI has been done, which is fine. Right is okay also?
Yes.
Right, it's good.
Okay, good.
Yeah, and Dr. Kinney's point is very appropriate, that you want a pigtail JY because you take big cells, especially after you can cross through the frame. Like we did at Percival one time, right?
Yes.
And you can actually get yourself in trouble that way. So you have to make sure your pigtail can cross without resistance. And you can see the pigtail is mobile as you cross on fluoro. That's how you know. If the pigtail is stuck in a certain point, then you know you threw something. And then, so don't proceed. You have to redo it.
Dim the lights.
And also, echo can also show you too. That's why TE is important. We have one case recently, we just showed last month. Our live case that showed was very difficult to cross, and the TE helped to make sure you go through the center because STEM actually showed us they were outside.
Yeah.
Right. So so that's very important to be able to differentiate that. So that's why I know a lot of people don't want TEE to guide these procedures. In my mind, this is a second chance. It's probably the only chance before going to TAVR explant. You want to do it right. You want to do it safely, and I think TE, should be done unless there's contraindication. Sam, can you comment on that?
You're actually not coming good, Sam.
Sam, can you show live?
It is shown, but not coming out good.
He's advanced.
Now we are talking. Yeah.
So, Stem, you want to just make a quick comment about that whole point about crossing the valve appropriately?
Yes, I mean, as we saw in the previous case, you thought that was through the valve, but it was in the PVL location. So it's very important to use every modality we can in order to have a safe procedure because, as you say, I mean, you don't want to put a valve in a PVL location and have a catastrophe. So it's very critical to use all modalities for this purpose.
So this is the 26 plus 2, right?
Yes.
Okay.
Plus 2 or we're just 26?
Plus two. Just go slow on the inflation.
Yeah, go ahead.
Pull the wire back.
Yeah, go ahead.
Who has the wire? Pull the wire back.
I have.
Yeah.
He has the wire. I'll take over
I have it.
afterwards.
Yeah.
Good. So, good. Perfect. Okay, let me flow save that, please. And then let me mag in for the crew.
Did you go through?
Hold the wire.
Did you go through the? No, he's holding.
No, wait, because I don't think you're. I don't think you're through the valve.
Huh?
Yeah,
We're not through the valve?
No.
No, we're through the valve.
Stam, it's okay.
Look.
Okay.
Yeah, Stam, it's okay.
Yes.
So
No.
here. So
Okay, hold on.
That's actually good.
Let me just. Okay,
so
you want to
remember-
tell us?
Yeah. So you can see that fluoro, please. Let's flow so the audience.
Okay.
So we want to start at roughly
1, 2, 3. Yeah, it's good.
2.5 because it might ride up, and you remember you have to account for this PVL, right? So I like this position. I know everyone
I
else
really like it. Yeah.
because you don't want to be deeper, you don't want to be too high.
Did you explain based on this angiogram?
Yes.
What
Why
how
don't you
we are
do-
going
why
to
don't you- why
position?
don't you
Yes.
show that?
Let's go back here. Not this one here.
Yeah. So here, why don't you explain that?
Yeah.
Group?
Hold on.
pause
Let's
that.
go back. You see it here?
Go back one picture.
This
Yeah,
is,
that's good.
Yeah. Let me just stop it. Hold on.
Yeah, well, definitely was very too deep.
Okay.
Good.
So
Yeah, show that. Go ahead.
can you see this now?
Yeah, yeah.
Yep.
Go ahead, Eki, you can
Everybody?
describe, yeah.
Yeah.
with
So if you see here, see where the node, if you are, how will I say? So the node 1, 2, 3.
Yeah.
So 3 is just above the annulus, right?
The
So
corner, yeah.
we want 3.5. So we will be a little bit above with the sapien valve.
Yeah.
yeah.
Agree?
Yep.
So
So
you
we
see
just-
the commissural tab, just below that commissural
a-
tab is your coronary risk plane. So you want to make sure you're there because end of the day, you want to seal where this annulus is. It's
Yeah.
not below because
Yeah.
the valve is very deep. You have to focus on the annulus. That's
Yeah.
why this picture is very important. That's what Dr. Kinney is saying, that you have to protect the coronary risk plane and still seal the annulus.
Yeah.
So we will be just below the commissural tab. We'll start lower,
Yeah.
try to land it there.
Yeah,
Okay, so now
let's fluoro,
on the
make sure.
fluoro, we counted the tabs. So
Yeah.
you see that 1,
So let's go a little bit
1,
higher.
2,
Good.
3. So we just like a 3
Yeah.
and a quarter. No, no,
Good.
you pulled
That's very
back.
good. That's
I'm
very
going
good.
in. I'm going in. I think this
No,
is
no,
better,
it's too deep.
Okay. Okay. Okay.
Yeah.
Good.
Here, there you go.
Okay.
Good.
So you are 3.5 now.
The 2 and yeah, one that from inflow
Yes.
0, 1, 2, yeah, 2.5, yeah, to
Okay.
3. Good.
So 180. Don't go up yet.
Yeah.
Let's just.
Lungs down.
Okay. Stable, right?
Sine. Just test.
Off.
No testing.
Looks good.
Yeah.
Off.
Okay. Lungs down.
Yeah, lungs. Okay, ready? We're gonna go
Okay.
lungs down again. We're deploying,
Okay.
right? Everyone?
Yes, yes.
Sine.
Okay. 180 and lungs down.
Go slow. Deploying. Very nice.
Mm-hmm.
Good.
Go.
Good.
Go full. Okay.
Okay,
Fluoro,
lungs up.
please.
Okay.
Okay,
Up.
off.
Off.
We
Okay.
are
Let
going
him
to do
breathe.
one more as
Let
we
him
have been
breathe.
doing it. Yeah.
So let's look at echo first.
Can you look at echo?
Yes, look at echo
There was
first.
some poking there.
Yeah. Fluoro, please.
No, we're okay with fluoro.
No.
Yes.
Oh, sorry. No, I just want to
Don't-
look
don't
at,
move,
no,
don't
take the
move.
parallax off. Let me take the parallax off first.
No effusion, nothing.
Huh?
No effusion,
No,
everything
no,
looks
I
good.
know, but where's the
How's the PVL?
Check the
PVL.
PVL stamp.
PVL, yeah.
We really didn't go full.
No, I was at pressures were high.
No, this is through the wire. It's not.
Can you look at your short
axis, Sam?
explain? Yeah, show that same location. That
Show
you showed
us the
earlier.
location where you showed us that.
Earlier.
Yeah.
Remember the 5 o'clock you were pointing
Can you
to?
put some color, prof? Some color. Yeah, there's nothing there.
Huh?
Nothing there.
Let's do
Nothing
one more.
good.
Let's do
Okay,
one
we're
more.
going
inflation.
back. One more inflation.
Okay.
Nothing,
Did,
nothing
you
there.
go
Yeah.
full?
1
done.
cc minus.
So,
Now
Pedro,
I'll
we
go
have
full.
made it that these kind of cases, even otherwise, try to do a second inflation just
So
like
this,
we do
through
for
center,
stents
center. Yes.
for a better
the
expansion.
Okay.
They have the cover.
Okay.
Correct.
Pace 180.
Okay, we're going up. Full expansion
Full.
or no?
Done.
Full. Okay. Okay, deflate.
Off, off, off.
Pigtail ready,
Good,
please.
good.
Let's get a pigtail.
Off. Okay, good. Coming
We'll
down.
do the hemodynamics. I mean, gradient should be less than 5.
The loader cap.
Yes,
Just
I'm
open very
taking it out.
nicely.
Yeah. There should be no leak now.
Yeah.
It's fully expanded frame.
And we do a good aortogram.
And no effusion.
No effusion. No
we do
effusion.
good
Okay.
aortogram.
You
But
got
No,
wire?
no, no.
You got
no,
wire?
No, no, no.
Got it.
Transplanted kidney
Okay, yeah.
with the high creatinine.
This is the previous location. No PVL. Nothing.
Yes.
We're gonna,
Beautiful.
We're going to
Wow.
exchange of a pigtail now. The
Pigtail
stem, so
gradient
then
and
you
we are
can,
done.
Then you can look at the PVL in more detail, okay?
In retrospect, I will say one thing. Dr. Kinney was right about the sapien valve. Up front, I will say that.
Yeah.
This is the experience she comes from. So, but excellent result. I think Gilbert and I are more cautious. But
Okay. All right, Stan, just
Okay.
a pigtail. Can you look at the PVL now,
yeah,
please?
yeah, absolutely, absolutely.
flash that also.
Lungs back on, right? Of course.
Yeah, nothing multiple. See, rotating the probe, nothing rotating again.
You want to do
nothing.
explain to show the audience? So
Yes.
yeah.
So this is posterior. There's nothing there. Now rotating again. go anterior.
3-4 minutes.
Nothing, if you remember, that was there. I think it's the wire. That's why you have a little bit there. Go to
That's
short,
the
go to
Can
short
you
axis.
explain? Can you show us explain, please,
Yeah,
Sam?
go into short axis.
Okay.
As you remember, it was around 7 o'clock.
And also 5 o'clock, right? Is that 5 o'clock?
Yeah, 5 o'clock below the left main.
Yeah.
See the left main around 2.
Yeah.
That's where the arrow is by Dr. Benjamin.
Yeah. Anything there now?
Nothing there. Nothing there.
Beautiful.
Nothing. All the way. Going
Okay.
deep.
And no gradient as well. Can you show the
Wide open.
hemodynamic screen, please?
Wide open. Coming up. Nothing. Everything gone. Nothing.
Yeah. Good. Now, can you show like echo and hemodynamic like all together, right? Yes, please. Thank you. Good. So yeah, so you can see no gradient across the valve just like before. So let's do a pull back and then we can
Give me the
make
wire.
sure then.
Give me a wire.
Yeah. So we like to use a wire exchange here because you have two valves. You don't want to get caught in anything that you don't want to get caught under. So
Beautiful.
very important.
I think
Going back.
position-wise couldn't be better, huh?
Yeah, so we end up in inflow. We were thinking about a little higher, but this is okay as long as you, like I said, this is a PVL, right, mechanism. So you don't want to be too high and miss the annulus, as Dr. Kinney mentioned. So in this case, with the valve implant a little bit deeper, so you actually, if you look at the valve deployment, you're going to be, this is probably roughly, if you had no Navitor valve there to start with, or you're just doing a Sapien, this will roughly probably be around 80-20 deployment. So you can see that here, and then you can see where it end up. And so, yeah, so this is obviously that's what you also aim for. And that's why it's important to look at the pre-TAVR CT. You can measure the left main height, you can measure the sinus height, you have all those references values, because in the angiogram that you see just now, you may not see the true annulus because there's calcium of the leaflet in place that's only opacifying the sinuses. So always keep that in mind. And even with the post-index TAVR CT, like you saw earlier, we still don't know where the true annulus really is, other than maybe some landmarks that you can identify. And so the left main height, the sinus height, the right coronary height, those are only references you have to measurements in terms of relative to the annular plane. And you can see that here, this will be a very nice, result in terms of expansion. Why are we doing this double tap now, Dr. Kinney? Want to tell the audience we're doing this not just for this kind of case, but also routinely now, right? In our native.
Ever since we started with the Resilia.
Yeah.
I think if people have started using Resilia, they know that it is a slightly stiffer.
Yeah.
And not easy expansion. So we think we'll do one expansion, and actually you've seen that when we do the second tap, that's the time you see a better expansion.
And
but by doing that,
right?
you do cine, you want to see it, and if you're not sure, do a quick echo in between and do your second expansion at that time.
So Stam, tell us about the these kind of cases. What are you looking for? As an echo imager in Redo TAVR. Like I said, I really want you to tell the audience about why people should do TEE as like a preferred approach. Because we talked about crossing, but what about assessing the valve, positioning the valve? Can you tell us?
Yes, absolutely. Yeah, I mean, one is to position the valve and to make sure that you are in the valve and not in the PVL, as we saw in the previous case. And the other is you have a better evaluation of the PVL, because as we know, these jets are mostly eccentric, so it's very difficult to see by transthoracic echo, and you may miss them. Even you can miss them with a TE. If you don't know, what. As I saw here, you have to rotate in multiple views, multiple angles, and also the deep gastric that we cannot show in this case because we cannot advance the probe is very critical, especially using the X-plane, and make sure that the AR is really a PVL or valvular. So very critical. And we know that TTE is limited on evaluation of PVL, so that's why, especially if you do valve in valve and the patient is anesthetized, I mean, there's no big deal to put the TE probe down and have a full imaging capacity.
And tell us about, there's some new TE probe technology coming now, right?
Yeah.
Tell us about the new ones, what the new probes. There's the micro probe, I think is that what it's called?
Yeah, there's a macro probe, which is a small size, but doesn't have the capabilities that the full size TE probe has, but has some uses, especially maybe on this case that we could not advance the probe to go deep to gastric. Maybe that probe would have been useful, but the problem is that the capabilities of the 3D of the small probe that is coming out is not as good as this one that we have now. So,
Right.
I mean, it's plus, minus, and also experience has a big thing to do, because
Yeah, so I think we're going to close now.
We're gonna close the groin,
just,
yeah.
closing the groin now.
You want to go over the slides?
And so let's maybe start the presentation. Dr. Sharma had to step out. But yeah, no, we were talking about the Philips probe. That's
Go
like
back to
smaller
the
probe, but that's the
presentation.
same
yeah, that's what I'm
capability,
saying.
right?
It's not
Presentation.
Can we
Slides.
go to the slides, please?
in some images.
Maybe they're not.
Thank you. Hafiz, thanks.
All right.
Yeah.
You want me to go?
Yeah, okay.
Yeah. Recent trials.
So as you know, there's been a lot of hot topics at TCT. You can see that all these paper presentation just came out a couple of weeks ago. So we're just going to go over it for the audience in case you missed the hot topics. So of course there's the asymptomatic severe AS, the early TAVR trial. Then it's the asymptomatic severe myocardial fibrosis, the EVOLVE trial. There's the moderate AS and LV dysfunction, the TAVR and low, and finally the late breaker accurate Neo2 versus commercial platform RCT in the United States. So of course this is the New England Journal paper by Philip Generou and his group, looking at if you randomize patient with asymptomatic severe aortic stenosis between TAVR versus watchful waiting, what are the differences and what are the results? So here's the trial. You can see that patient 65 or older, STS score less than equal to 10, severe AS, but confirmed by a core lab. And then you have to be a negative stress test. So these patients actually get stress tests when they can. Obviously, not everyone can undergo a stress test. And then you get randomized between a Sapien-3 platform, transfemoral TAVR versus surveillance. And you can see these are the primary endpoints for superiority, particularly not just all-cause mortality or stroke, but actually unplanned cardiovascular hospitalization. And we'll define that in a moment. Of course, they're the usual secondary endpoints. So here's what the trial flow looks like. You can see that here, roughly 440 patients on each arm getting either TAVR or surveillance, and the number exclusion, and this is the baseline characteristics. So surprisingly, despite the inclusion criteria being less than 10% STS score, most of the STS score patients are low risk, 1.8%, and they're young, 75. So this is actually very much close to the partner-free low-risk trial in terms of the demographics. There's still 8% of patients bicuspid that were not excluded if deemed suitable. So here's the primary endpoint. You can see, wow, right? So within the first 6 months, there's a huge separation of the TAVR group versus the surveillance group, and you can see that the curves stay parallel afterwards, and the number to treat at 2 years is only 6 patients to avoid getting into primary endpoint. And you can see that here, the primary endpoints, you can see it's statistically significant. The mortality is no different. Stroke is really no difference between the two groups. The unplanned hospitalization was the one that was significant. And the definition of that was actually conversion to aortic valve intervention because of symptoms. So this is a crossover. So that's really what that was driven by. And you can see that these are the separation curves. And so basically, a lot of these patients actually presented with symptoms at 3 to 6 months. And that's why you see this huge separation. Most of them, based on the presentation, were shortness of breath. There were other issues and also progression as well. Of course, you can see that here they all significantly improve based on the quality of life index afterwards as well as follow-up. Interesting. You can see that here there's also a LV remodeling as well in evidence.
See the aortic now?
So you can see that here, this is why I'm talking about the conversion. A lot of patients already converted by, 83% of them actually by 6 months to a year. So you can see that this is the reason why, this trial is positive. And you can see that here again, as well in terms of potential signs of symptoms at now 3 to 8 years up to longer follow-up in the trial. So in summary, you can see that with early TAVR was positive, mostly because a lot of these patients are actually becoming symptomatic at 3 to 6 months. So I want to ask Dr. Keeney here, what's the message here for the audience in terms of, should they get TAVR earlier or should they just be seen sooner? What's the message for the general cardiologist?
I would say symptomatic.
Yeah.
I think what this trial is telling us is as soon as symptoms are there, this is for early TAVR only. I'm not talking
that's
about
right.
the
That's
others.
right. Yeah.
Yes.
So here, what are your thoughts?
No, I think really there's no true asymptomatic patient. I mean, if you have critical or severe aortic stenosis, you automatically limit your activity to sort of, come to terms with your cardiac health. So, a true asymptomatic patient doesn't exist. In my mind, that's what this trial is showing, that what we perceive as asymptomatic, they are actually making adjustments in their life. And it's just a matter of, when they have an event. So I think all these patients, if they have definitely critical, but if they have severe aortic stenosis, true calcific aortic stenosis, they should be offered TAVR if they're appropriate.
Yeah, and it should
the
be also
difference is critical versus
right,
severe.
and that's exactly right. So the point here, I think, is also that watch them closely.
Watch the
Right? Don't wait till 6 months to do an echo because a lot of them are already presenting at 3 months. So that is the early TAVR trial, and then Dr. Sharma is back right on time to talk about the evolve.
Yeah.
So here you go.
So one plus. So we got just like our surgical 2 trials.
Yes.
So now we got your only question remain if you the many patients in the clinical surveillance and wait and watch also got the TAVR. So pure difference which we'll never know it. We'll never know it. But anyway, the key is there's no reason to wait. The only point I wanted to make on this that some patients, about almost 25-30 patients, require TAVR for urgently. So that's question is, so because of acute decompensation, I'm sure they got a little more LV dysfunction, some fibrosis. What will be the long-term effect of that we need to see. Now, second group, to the same, this is from UK and Australia, also looking into asymptomatic patient, but they say let's go with the myocardial fibrosis. So there is an MRI with gadolinium, enhancement, and patients who had fibrosis, they say let's do now in these particular cases, same about 240 plus patients, that see that what happens, conservative management or early intervention. So overall, were comparable, different time to intervention. As you can see, conservative versus aortic valve intervention. Even conservative group, as you can see, almost 80% will require some at follow-up of 3 to 3.2 median, and these are the individual endpoints. Basically, compared to what we saw in the early TAVR, little different data on this evolved. That is, all-cause death or unplanned AS-related hospitalization, although was numerically lower in the early intervention, but not significant. Same also the death or unplanned revascularization, the only one, if you take only point, unplanned AS-related hospitalization was different, and part of that, whether it's because acute deterioration of the condition and that required the urgent TAVR. If you have planned TAVR which was not counted, we know that how many percentage got it. Now, stroke, or again numerically lower but not significantly lower, as you can see here 7 versus 13, but maybe a small number. We know if you plug in with the 1000 patient, this will become significant, but numerically these are the individual endpoints shown here. So basically the central figure showing that overall event early intervention 18% versus 23, composite primary endpoint, and no different. So therefore conclusion was, the authors of this, that in asymptomatic patient with a severe AS and myocardial fibrosis, early aortic valve intervention had no demonstrable effect on all-cause death or unplanned aortic stenosis-related hospitalization. Gilbert, what do you think? Why that happened? 2 contrast studies, both have similar criteria, valve area less than 1, gradient more than 40, peak velocity more than 4.
I think it's just the way they are followed, and you can see obviously the sample size is quite different. But clearly you see that the unplanned hospitalization is quite higher, right, in the surveillance group. So I think the message is similar. It's just you may not see it on the MRI finding, but they might be presenting clinically.
That's it. Yep. So, okay, but we at least have the 2 data now with us. Yeah. Okay, so this basically was that in asymptomatic patient with severe aortic stenosis and myocardial fibrosis, early aortic valve intervention had no demonstrable effect. Trial primary. Now, then we have the trial of the TAVR unload. And TAVR unload basically was the patient with a moderate aortic stenosis and LV dysfunction and heart failure. So what happens? Because always we know aortic stenosis is a high afterload. So if once you have high afterload, what are you going to do if you take away that the high afterload, and that is by doing the replacing the aortic valve. The concept wise,
uploaded slide, new slides.
No, we just get questions. Yeah. So basically, there are data to support that moderate AS the patient with the moderate AS do worse, particularly those who have heart failure. Very important. These are the historical data. So then question comes, and then of course death occurs in the patients with the event, basically low EF. Even the EF is normal, which is like more than 50, so event rate does happen low. But what about those patients with the EF of less than 50%, and they do die from the diabetes, CAD, and LV dysfunction? Those are the predictor. So then the key is that what if we take away this afterload reduction by replacing the aortic valve? So this is the trial of the unload trial. Took a lot of time, slow randomization, so slow enrollment. They finished it before time. The TAVR patient versus continued surveillance. Patient has to have good guideline medical therapy, moderate AS defined as 1 to 1.5, and you can see the bottom criteria that if it's less than 1, then you do the dobutamine stress echo or valve index, particularly patients who have a high body surface area. EF less than 50, and those are all suitable for transfemoral TAVR. Primary and secondary endpoint shown on the right side. And basically, what did we learn with these? Okay, I don't know what is happening. Okay, good. I don't know. Okay. All right. So these are the individual group of how the patients were followed. In their all-cause death, the 30-day TAVR outcomes are excellent with a low complication. So even in these patients in the continuous surveillance group, the 43% required TAVR. So even with a moderate aortic stenosis, many times because of progression, as you can see here, with the TAVR for the severe AS, or patient has still moderate, but they were symptomatic. So 39 plus 4, 43% require follow-up TAVR in this patient. All these were done with the balloon expandable. These are the follow-up. Overall showed that by changing the valve early, like preemptive, in this patient with a moderate AS and heart failure, there was no benefit as shown by any count. With the disease hospitalization was slightly lower, but again not significant. So overall, you can say the only thing improved is the cancer city, our quality of parameters. So quality of life parameters definitely were better in the TAVR group compared to surveillance. So therefore, TAVR was not superior to AS surveillance for the primary hierarchical composite endpoint in patients with moderate AS and heart failure, low ejection fraction on guideline medical therapy. Preemptive TAVR for moderate AS was safe and may provide clinically meaningful quality of life benefit, but no survival. Any surprises here?
No, I think the people, again, once you get symptomatic, you have to treat the patient, So there's very few patients who remain that for that period of time. And just
It says, what about the ejection fraction for people very low EF? Previously, they show they
they made it between So in this group, there were 20 to 50% EF, and there was no change in the ejection fraction. But remember, because 43% required TAVR in the other group. So let's go back to slides. Okay. So just 1 second, they're coming back to it. Okay, so therefore that was the conclusion. The last one I want to just show quickly is the Accurate Neo 2, because this is the first largest randomized trial of comparing the Accurate Neo 2 new platform of the Boston Scientific. Initial data looked very good, and this is a slightly different design. I mean, you can call it a hybrid type, but the easier felt that you will be able to get to the coronary access better, and the better valve expansion. Some data did show that it also comparable aortic valve area orifice was much higher with the Accurate Neo 2. And that led to the randomized trial of the Accurate, about 1,500 patients, one of the largest trial. And of the control group, Evolute was 244, Sapien was 544. So it was like 60-40 split. And then overall found that our Accurate Neo valve was not non-inferior. So by the definition, it was inferior, double negative. And the individual endpoints are here. That you see the hospitalization 14.8 versus 9.1. Individual endpoints of the death, stroke, and hospitalization all numerically were lower. So overall, the trial concluded that it was overall the negative trial. Only question was, what about the valve area and velocity? So valve area, it has little plus point. I would say the mean gradient is lower, similar to our self-expanding, but a little better than the balloon expandable. But rest of it, as you can see here, it is still quite a high. On the right side, you see paravalvular regurgitation, and they say it is because of under expansion. We learned that also very early, right? I mean, this question was, should we have dilated bigger valve? I mean, with a bigger balloon in cases, because everyone require post-dilatation, right?
Well, this one, everyone required pre-dilatation to the mean diameter, which is very aggressive. Post-dilatation is at the discretion of the operating team, but now we learned that we have to post-dilate, which of course has its own risk as well. So, but the 40% mild PVL 1 year is pretty much unheard of in current generation valves, right? We're talking about the historical first generation valve that you see that kind of rate. So this is a bit disappointing in that regard.
So one thing is post-dilatation, but also we have data now that the accurate neo, if you have commissural malalignment,
Yes.
there's high risk of PVL. So it's
That's
not
right.
just the frame itself.
Correct.
It's something about the suture lines as well.
That's right. That's why Accurate Prime
Yeah.
reinforces the commissure area, and they want to get commissure alignment to reinforce that for paravalvular leak. But it's not feasible all the time.
So therefore, so question, there are various points here. My only question now, knowing with this, and knowing the lot of investment of the Boston Scientific had done in the accurate generation, are they going to bring it to the market? But FDA probably will not approve it, right?
No, we don't know.
Unlikely to approve.
It's difficult.
Very difficult. Although it was not harmful.
Yeah.
It was, but it was not inferior.
Well, there was also
Yeah.
high risk of stroke in the Accurate arm. That was it was inferior for that reason.
Okay.
So it was a non-inferiority trial, turned out to be inferior.
Okay.
So that's the
Or also,
concern.
I think they will have these two or three, 2.5 valves. I mean, clearly, there are a lot of trials ongoing with the with Navitor now, and we are part of the trial. Tell us a little bit
Envision
about
trial, yeah. So Navitor is right now approved only for high and prohibitive risk patients. The Envision trial is enrolling for intermediate and low risk. So let's see how that does. It's one-to-one randomization with a commercially available platform up to the user discretion.
the same way what we did the Accurate Neo.
That is
And
correct.
how many patients will be?
Around 1,500 patients.
Same way.
Yeah.
1,500. Okay. All right. So very quickly, let me just complete all three. The patient wait and watch policy in an asymptomatic patient not needed. If you patient qualify, you replace the valve. Now only question is this whole issue about fibrosis. There was no difference. I think it still need to be more evaluated. Second, moderate AS patient with a guideline direct medical therapy, there's no reason for us to push for it. If patient really becomes symptomatic and AS progresses, then only, but we cannot say preemptive TAVR is indicated. Then the randomized trial of the Accurate Neo, as we have just discussed, will be a tough one to bring to the market. It's with the valve trial data. So therefore, just to quickly, three questions. Following statements are true about the results of the early TAVR, comparing TAVR versus routine surveillance. Primary endpoints were lower. With TAVR, the stroke rate was similar between two groups. More than 95% of the patients surveillance group received TAVR, and TAVR resulted in LVF improvement versus surveillance group, and answer is D is wrong answer. Then the no, they were supposed to they were supposed to get those two other questions.
Yeah, okay. Correct is B.
Okay, all right, good, fine. So this is one done. We have the whole team working on it. Then TAVR unload trial comparing TAVR in moderate AS with the heart failure versus clinical surveillance showed the following, except all-cause death similar, trend towards higher stroke rate. TAVR was implanted more than 75% of cases in the surveillance group, and similar heart failure hospitalization between two groups. As you can see, implanted only in 43% of cases. Then lastly, that evolved trial data of the asymptomatic patient and myocardial fibrosis, the death rates were similar AS-related unplanned hospitalization, composite primary outcomes were similar, and stroke rates were significantly lower in the TAVR group, and answer is again D, not true. With that note, we'll complete our presentation today with excellent case implantation, understanding the issues with the current valves, and hopefully we do a better job, I would say, in the future to give more sustained benefit to our these sick patients.
So a very important announcement. We're having our New York Transcatheter Valve Symposium on Thursday, December 5th. This is the first Thursday of December. I'll see you there. Thank you.